Move on then to our final speaker for today, Dr. Sarah Rhodes. Allow me to introduce her while she comes on camera. Dr. Sarah Rhodes is an occupational epidemiologist, a microbiologist, and an advocate for worker-driven research. She was trained at the University of North Carolina, where she conducted research in partnership with agricultural workers to evaluate their exposure to antibiotic-resistant bacteria from concentrated animal feeding operations. In 2019, Sarah began working with OHCOW as project director to employ epidemiology as a tool for investigating health concerns raised by Ontario workers. In her downtime, Sarah enjoys spending time near the water and cooking delicious meals with family and friends. Welcome, Sarah.
Hi, everybody. Can you hear me all right? I hope so.
Yes, I can.
Yes.
I can.
Okay, great. If there's ever an issue, just let me know. I'll try to check the chat as I'm going, just in case. But let me go ahead and share my screen. Alrighty, and if I can get confirmation that you are seeing just the slides, we'll see in just one moment.
The slides and just
is that
yes,
is that all right? Is that coming up?
Yes, looks like the presenter view. Yes, it's all good.
Perfect. Okay, great. Thank you so much. Well, I'm so glad to be here, everybody, and it's great to see such an awesome turnout at October today on the 20th. My name is Sarah Rhodes, and I am a project director at OHCOW, as Megan previously said. But today I'm going to be following up with Dr. DeBono's talk to really bring some even more kind of worker-driven examples of how under-recognition and under-reporting of occupational disease is so prevalent and the factors that influence this issue. And we'll definitely be speaking about the role of worker health clinics in this process of improving recognition and reporting of occupational disease. So with that, I'll get going. So to provide an outline, first I'm going to talk about the factors that drive under recognition of occupational disease. I'll be really hoping to bring forward the worker perspective, at least from what we hear through workers coming to our clinics across the province. I'll speak about how OHCOW is trying to develop clinic-based solutions to these issues, and then hopefully open up for some questions and discussion. But first and foremost, speaking of the worker perspective, I just wanted to provide some context around the images on the right. We have on the top a really powerful photo of the McIntyre powder miners who were non-consensually exposed to McIntyre powder in their careers in the mines up north. And then down below, we have a photo of the historic rubber workers in tire manufacturing in the Kitchener-Waterloo area. So when we're talking about the underreporting and underrecognition of occupational illness, I think the biggest challenge is how we can be addressing this question that workers come to our doors with every day, which is there a connection between my work and my health? And the reason why this question can be so difficult to answer is that there are so many different contributing factors that can contribute to our health, especially given the fact that we have spent so much time at work, but we also have other environments that we move through throughout the day and throughout our lives, including on the right, our home and community environment. So we have air quality in our home communities, air quality in our work communities. We have workplace chemical and other like chemical physical exposures or hazards. We have also mental and psychosocial conditions, such as harassment in the workplace that can come into play. We have personal health behaviors and our own kind of personal health factors. And then we also have things like family history of illness that can impact how we move through and develop illness in our lives. So we are really, when we're trying to answer this question for workers around there being a connection between a workplace exposure and health, we are also needing to consider the influence of a lot of these other factors, but while also really understanding the workplace itself. So I will move from here. And so the first piece that I wanted to really dive into is underreporting of occupational illness. So when I say this, it really is truly simply that workers reporting illnesses that they experience at work, and especially also the role of also employers in supporting workers in doing that in the system, the Ministry of Labor, OHCOW, other organizations, primary care providers, understanding and reporting illnesses that may be connected to work when we see them coming through our doors. So there's factors here that I'm going to walk through, but the first on the left is that oftentimes we see underreporting of occupational illnesses because it is so difficult sometimes to recreate our exposure history throughout our working lives. So oftentimes, especially for me as a young person and as a young worker, when I was 16 working in a restaurant, I did not have the education or information to know that I should be tracking what I'm exposed to in the job that I'm working at age 16, not to mention moving forward in our lives, especially if you don't have access to that type of information. So oftentimes workers aren't tracking exposures that they're experiencing in the workplace themselves, but also that's something that we've really seen that's important from the standpoint of systems in place to help workers doing that, including employers, keeping records of what exposures exist in the workplace and safety data sheets, et cetera, providing training around those things. So, and especially when we're looking at studies in studying these issues, it can be difficult to actually really create that exposure history. So that's one major issue. The other piece is lack of educational resources and training for primary care providers. There's a growing body of physicians and other care providers who have been provided with environmental and occupational health trainings to basically provide information to them around when they see patients coming into their clinics and they see potential illnesses coming forward, that they are also asking the workers about kind of an environmental and occupational sort of questionnaire for the workers they're working with. Or in that case, they're not even necessarily seeing them as workers, they're seeing them as patients who are coming in. And some care providers may not even think to ask about work and the role of work. So that's something that we really need to be working on and ensuring that that is brought forward as a priority in order to increase the reporting at the clinics themselves that are not even an occupational health clinic. We also have been in the Ministry of Labor and OHCOW, and a lot of the other health and safety organizations, we are very much tasked with improving OHS trainings. And by OHS, I mean occupational health and safety trainings for workers and employers to just raise awareness about the fact that your work can contribute to health, and that is the environments that you are in do influence your body. So that's something we know is a factor that might influence underreporting. There's also issues that we've seen, especially in the clinic, where workers will come forward with issues around access to the compensation system. Sometimes people will say, I believe that there's a connection between my work and my illness. However, I have heard that there's long wait times at the WSIB. I've heard that there's, for some workers who don't speak English or French as their first language, they fear going through the process at the compensation board without translation services that are appropriate or timely will prohibit them from ever reporting something, especially in the compensation system. And then staffing issues. So we've seen those come forward at the clinics. Underreporting can also be driven by inequity and intimidation. We've seen that workers have come in and said, I'm intimidated to report an illness that I'm experiencing because I'm afraid I will lose my job, or there's kind of misinformation around what will happen to workers if they do come forward with an issue. Intimidation has been reported to us of people experiencing that, which is also a mental health stressor. We also see a lot of research coming forward about inequity, which I'll speak to on the next slide. And then lastly, another issue that's come forward in our clinics related to underreporting is that oftentimes, unless there's workers who, especially for conditions that are more rare, unless workers are speaking to each other and kind of hearing more about the fact that, I have a rare form of a disease and I see that 4 of my coworkers do, and I wonder if that's a signal of something. Oftentimes rare conditions are really, really missed. And sometimes people think, this is a rare condition. My doctor told me it's a rare condition. There's no way it could be related to work, for example. So those are hard to capture, as well as severe illnesses. We've had workers come to our clinics who've said, my father had a severe neurological condition and we just didn't have the capacity to ever even apply for WSIB given the nature of the condition itself. So there's lots of factors that come into play with underreporting that we really need to be opening our eyes to and developing solutions for. As far as underreporting, I just wanted to pull a couple of statistics and information that have come forward recently to really highlight some of the pieces I just mentioned in the last slide. So the first is accessibility limitations for vulnerable workers specifically. The Institute for Work and Health have conducted research. So the top two pieces here are from the Institute for Work and Health, that newcomer workers especially are more likely to work in physically demanding jobs, be exposed to occupational health and safety hazards, and lack adequate access to protective workplace policies and procedures. Specifically, you'll hear more about this next week at our October sessions, but we have seen workers who, especially if they do not have a clear time or ability to, or especially the language issue as seen here. Workers are intimidated to go through the process of even reporting their illness. They do not go forward, and especially newcomers facing a lot of the issues that they are facing, this is even more of a barrier. And specifically for the language piece, in the Institute for Work and Health research study, more often the study team heard of medium and small size employers trying to overcome language barriers through more informal means as opposed to formal services, such as using online translation apps, pairing newcomers with buddies who speak the same language, or asking family members to help interpret OHS training and onboarding sessions as opposed to that coming from the employer or through an official translation service, for example. So those are things that could also suppress reporting of illness. The compensation system setbacks, I've mentioned a few that we hear from workers, but we've also seen that there's been more reports at the WSIB as of late related to reports amongst their staff of understaffing, as well as long queues, where I think even workers at the WSIB who've reported that they've felt that burden too of worrying that people are waiting a long time while they're also experiencing injury. So we've seen those two come forward in recent data. And now I'm going to move towards I spoke about underreporting. Now I'm going to speak about under recognition. So when I speak about under recognition, I really mean now some of the kind of moving into what Dr. DeBono was speaking about. How do we see ways that are put into place where connections between a disease and illness, or a disease and work, are suppressed or under recognized by the system, by research, and so these are some of the ways that I'm going to speak about now. For under recognition, one of the first issues is truly biases and limitations that are inherently present in some of the occupational health research that exists. A lot of times we're dealing with retrospective exposure research studies where we're really, again, trying to study plants that sometimes, for example, have closed, and there's only a limited amount of information where you can maybe only look at the influence of working in the industry itself, not necessarily having a lot of information about specific exposures or specific departments. So that's something that we see that often that can lead to potentially under recognition over time. I'm speaking here to influence from industry funded studies. So this is one that Dr. Zabona spoke to, and I think that's a very interesting piece that in the work that he's done to really show that, if we can create tools that allow us to stratify systematic reviews based on industry funded studies versus non-industry funded studies, and see if that does shift results. Even in the compensation system in Ontario, that would be an interesting tool for us to be considering moving forward to try to reduce or eliminate the ways that might bias results. Another piece is one that we see is limited I put epi here. Epi is epidemiology, so limited education amongst sometimes occupational health consultants in the field of epidemiology, and the ability to actually break down and understand research results and interpret them and synthesize the evidence coming out of groups like the the International Agency for Research on Cancer, et cetera. So that not only is the need for potentially physicians, as I was speaking to before, or primary health care providers to have more occupational health training, but also even amongst occupational health physicians, being able to boost the training in epidemiology, especially if they're commenting on evidence synthesis for claims, especially. Lastly here, I'm going to speak about a couple of others. There's been more discussion as of late around frameworks for causation. And when I say causation, it really is basically, for example, if a worker files a claim, the end point where someone is deeming, yes, this disease caused this, or this work that someone was doing caused this disease. there's been there's a lot of different models that have been created over time in the scientific field in order to better assess causality or causation between diseases and exposures. However, sometimes, especially from an epidemiology perspective, these criteria can be applied inappropriately, which actually, if some of you have seen Dr. Demers' report on the use of scientific evidence and principles in work compensation or workers' compensation or work relatedness of cancer, that report I'll also show on a slide coming up, but that is one that these topics are very much more discussed, and I'm happy to answer more questions on those. But then lastly, we have also, in a similar vein, sometimes to the rare conditions I spoke to before, sometimes because rare conditions are so underreported, they also are underrecognized given that the standards that are for causality applied to those conditions can be the same as for other conditions that are more common, which is sometimes can make it so that those are very highly underrecognized, even though rare cancers, for example, compile and make up almost 20% of all cancers coming forward in Ontario. So there's a lot of these issues that need more attention. As far as under recognition, I just wanted to pull, again, some statistics to kind of speak to some of those points that I just brought forward. At the top here is the report, a copy of the name of the report I just spoke about with Dr. Paul Demers, that I was lucky enough to be a part of preparing the scientific section of this report alongside Dr. Demers. But this report does really bring forward some of the issues around under recognition or the potential for under recognition of occupational disease. This chart here shows that in a cancer burden study that was conducted by Dr. Demers and the team, there was specific exposures such as asbestos, solar radiation, diesel engine exhaust that were, they looked at the predicted number of cases that we would expect to see in Ontario and then compared that to the number of accepted claims that we actually see through our compensation system. And you can see really a discrepancy here that starts to reveal itself. For example, with asbestos, 140 predicted cases were predicted, and then only 80 accepted claims came through. For solar radiation and illnesses associated, 1,400 predicted cases, only 24 accepted claims. So you can really see the discrepancy here and potential for under recognition of occupational illnesses. The next piece I want to talk about is actually related to our kind of evidence synthesis process, and again, kind of answering from the compensation, especially the compensation board, but also just the scientific community, how do we actually answer the question of, is there a connection or association between certain illnesses and a certain work environment or work exposure? And the International Agency for Research on Cancer, the group that Dr. De Bono just spoke about, recently published a publication that's called Bias Assessment in Case Control and Cohort Studies for Hazard Identification. I would really, really recommend people, especially at least read the first chapter. It's very, it explains the IARC monograph process and how they really synthesize evidence across different types of illnesses and exposures, but also very much describes how we can better understand how to interpret the evidence coming out of that group. But what was really striking to me was that in the first paragraph, the first chapter of this issue, they really spoke about how over time we really see evidence build for connections between specific diseases and exposure. So for example, at the IARC, they usually will classify kind of the strength of evidence into sufficient evidence as one of the higher categories, and then limited evidence based on the level of evidence present. But I'm just going to read these quotes directly. So over the 52-year history of the program, there have been many opportunities to examine this question in detail. During this time, a determination that there is sufficient evidence of carcinogenicity in humans for at least one cancer type has almost never been reversed. So this is powerful because truly when IARC has deemed something to have sufficient evidence, it's never usually over time had evidence come forward to reduce the certainty in that decision. So sufficient evidence really, once something is deemed to have sufficient evidence, it really continues to stay in that category. But then also the next one is even more powerful. For agents with limited evidence, so some of the disease and exposure or disease workplace associations that we see that have limited evidence in humans, such as arsenic and dioxin in this case. As time has gone on, the evaluations have advanced. Generally, they do advance to sufficient. So also this is something that I think is really important in the under-recognition of cancer, especially cancer-related relationships. We do see that truly like time and there being more and more research coming forward. If something has limited evidence, generally over the history of the monograph program, there's been motion towards sufficient. So I think that that's something that sometimes we see that the limited evidence category can be interpreted if we interpret that in the context of time. That is a really important point. So all that to say, kind of to wrap up this piece, underreporting and underrecognition really go hand in hand. You can imagine that if we have underreporting of illnesses, then ultimately there's not going to be as much evidence that can be even available, and that will lead to underrecognition. But also we've seen that when something is underrecognized, so for example, for workers who have gone through and there being rare conditions where there's maybe limited evidence of a connection between the workplace and the illness, if something's under-recognized, sometimes that can discourage people from reporting it. So you can see how these kind of go hand in hand and they really drive each other. But also I put at the base, I think it's really important that what we've seen as well is that inequity, discrimination, and intimidation in the workplace drives both of these. And it really is one of the biggest issues that is needing support, as well as kind of under-resourcing of the occupational health and safety system in general. So I want to now move into kind of talking about how we are trying to address these issues at OHCOW. But first, I'd like to really take a moment to touch on the worker perspective. So this is a compilation of a lot of different news articles that have come out about various workplaces that people have come forward with concerns about their health. Some of you who've worked with OHCOW or know about OHCOW and the work that we do, you might know of the stories of the General Electric Peterborough plant, Venture Plastics plant, the rubber worker group, McIntyre Powder, exposed miners, among many others. We work with many different groups. In the middle of this slide here, there's been more and more work with nail salon workers who have concerns about health. So there's many different worker groups have really come forward and brought and put themselves on the line to tell the stories about what they're experiencing at work, and also to really speak out about the injustices that they've faced in going through the health and safety system and going through the workers' compensation system, and trying to drive change and drive policy change as well, and combat underreporting through speaking out. So I did just really want to recognize that this is where we've been driven from. I wanted to also speak to this particular example just to show that, truly there's a lot of these pieces about underreporting. It's so powerful to see some worker groups that really come together and in community have started to either sense something is wrong, seeing people at their workplaces get sick, coming together, telling their stories collectively. And this is one example, the Venture Plastics plant in Peterborough. This is a really powerful photo because Rose Wickman and Jackie Duffy, who are two workers at the plant, had compiled obituaries of their friends and families as they start to see people pass away from cancer at a rate that they would expect was higher than what you would think was to be normal. So it was really powerful. This image was published in newspapers, and their stories were published, and they were really brave to put those out, and also came to OHCOW to ask for support in investigating these issues. So really underreporting is so driven also by workers coming together in community with one another to seek support, even though it should not be that we have to wait for workers to get sick in order for this to happen. So, and not only is there the workplace issue, I just wanted to also say that for this particular plant, there's been more and more markings of Environmental Protection Act violations. So even communities neighboring the plant have been complaining of sense of like for VOCs and other issues. So that's something that it really does show again the example of not only does our workplace health impact the environment, but the environment impacts our health as well, and neighboring communities can also be suffering. So that is just one example I wanted to raise. And so now what I wanted to do is go through just an example of, in order to better show you kind of how OHCOW is hoping to combat underreporting, underrecognition of illnesses, and support the kind of advancement of interventions on these issues. I wanted to just go through and show you an example of one of the projects that we've been working on, and really just to highlight our process and what we're hoping to continue to do, and of course get more feedback from many parties in how to do this even better moving forward. But if you do not know of OHCOW, I'm sure many of you do here, but we are a network of occupational health clinics across the province. We have clinics in almost every major city in Ontario, and we have a really unique group of staff members, including client service coordinators, occupational health coordinators, nurses, physicians, hygienists, ergonomists, as well as product directors and executive directors. So we have a very wide breadth of skill sets at OHCOW in order to try to help people answer these questions. Specifically, is there a link between my illness and my work? And also, how can we improve safety in the workplace, first and foremost, especially if people are still working? So one of the services that we have provided over time for a long time is what we call an occupational disease cluster investigation. So some people may not know what a cluster actually means, but I wanted to break that down for everyone here. So a cluster is basically a group of people. So you could think about a group of coworkers or people who all work at the same plant in a shared space. So for example, a workplace or a neighborhood, who have developed a shared health problem. So for example, say there were 10 out of 200 workers in a plant that all have kind of shown up with a rare cancer, and there's concern growing at a higher rate than expected. So for example, maybe we would only expect to see 1 out of 200 people diagnosed, but we're seeing 10, just as a very simplistic example. And then also over a certain period of time. So it's also, in order for something to be deemed a cluster, it also needs to be over a certain period of time that we're looking at this kind of higher or elevated rate of a certain illness amongst a group. So that's how it's defined, but we have worked with workplaces who expect that they have clusters of illness in their workplaces. And one of the groups we've worked with is the group of rubber workers that are in the Kitchener-Waterloo area. So just to provide some history, one of the main kind of ways that we try to capture and also combat underreporting of illness is through something that we call intake clinics, or an information session. So in 2002, the United Steelworkers hosted an intake clinic and started engaging OHCOW with issues that rubber workers were bringing forward around their health. And in 2019, there was a much larger intake clinic that involved OHCOW, USW, and the WSIB, where over 300 workers presented with their family members to basically document their stories of the illnesses they were experiencing, the exposures that they were experiencing. And then since then, there's been a huge process of the claims that have been put in the compensation system for rubber workers to work through those and better understand, is there a clustering of illness here? What do the illnesses look like? How do we determine that? But also, how do we make sure that rubber workers can come forward and report illnesses, and that this is not an underreported area? So we've continued that work, and we just actually had a info session in 2025. This past fall. I wanted to just show a photo of the team. So this is our team, including our hygienists, physician and director, client service coordinators, and nurses. So we had almost 40 workers come to this last session, and that's on top of the workers we already have in the growing database of rubber workers. A few other examples of intake clinics. We've had a session with the plastics workers. In this photo, you can see specifically Jackie Defty, Sherry McFadden, who are two of the workers who've been really active, as well as our team members. And then I wanted to show another example of the intake clinic we held with McIntyre Powder Miners, very much led by Janice Martell. But really the powerful piece about these intake clinics, which I think is definitely the gathering of workers to share their stories in community and to capture those stories from the disease perspective, but also from the exposure perspective, and trying to do that really hard work of trying to recreate the exposure history that has occurred in a certain industry or in a specific plant, so we can really get a better idea of what was going on in order to see if we do actually see connections between certain illnesses and certain exposures or working in a certain area of the plant. But also not discriminating against workers with any particular illness, and describing the kind of process as we go very transparently. So with the rubber workers, we are only here really with them because of their voices. They have come forward and have experienced various types of cancers, including GI cancers, prostate, lung, bladder, hematological, head and neck cancers, respiratory issues. You can see that the list goes on, and this worker group has really suffered from many, many different illnesses. Some of the information that we also tried to gather in order to address the kind of under-reporting, under-recognition are looking at the workers, if workers do decide to put in a claim, which sometimes they do not want to, given various aspects. So for example, so that's also one where we're still tracking their information, even if they don't want to put in a claim, to combat that piece of underreporting related to just not wanting to go through the claim process. There's the highest number of cases we've seen were GI cancers, and you can see here the red is the number of those cases that were allowed. By allowed, I mean they were accepted as having connection to rubber work in the compensation system. But you can see that there's also a large majority of those that have been denied and were not deemed associated with the rubber industry. So we are able to kind of see across the different illnesses, the kind of difference by the way that they are kind of deemed connected to the rubber industry or not. And we are very much using the expertise of our entire teams to better understand whether or not those associations are, have a deep level of evidence that should be going forward as an accepted claim. But yes, so we are going to keep going from here. Let me just do a little time check too for myself. So I'm wrapping up here, but basically what we want to move forward with and really speak to is that for worker support, it's very important for us to combat underreporting by collecting health and work histories, creating a database of worker stories, ensuring that they're able to have the resources that they need to connect to the legal system and the claim support system, but also most importantly, if they're still working, to ensure that they have access to educational resources. We also are creating a database that is allowing us to better understand if there are diagnoses or kind of are diagnoses that have gone through into the compensation system that were denied, that actually are potentially, that there is evidence available that would show that there might be a need for an appeal of that decision. For example, we're reviewing scientific evidence. If we are finding trends coming forward, we're hoping to publish our own studies as well. One example is actually related to a rare condition that as I mentioned before, if we weren't doing these intake clinics, sometimes I think we would really miss some of these rare conditions. In the case of rubber workers, it's salivary gland cancer. This is a very rare cancer, and we've seen more of these cases come forward in the rubber industry. And I think if we weren't capturing them at OHCOW, they might have slipped through the cracks. So I just wanted to show that one example. And so I'm going to wrap up here. This is my final slide. But I think the key takeaways from our OHCOW process are that we really want to combat underreporting and underrecognition through the early and comprehensive evaluation of workers' concerns, actively listening to workers, respecting their experiences as a form of evidence, especially through our intake clinics, documenting the diseases, exposure, stressors that they have brought forward, but also really making sure that we're transparent in that process, that of course there are so many different factors as well that come into play with each diagnosis. So just mostly trying to inform people, if there is not enough evidence at this moment related to a certain illness and work, we want to explain to workers why that might be true, provide resources, better describe what's going on so that they are not left out to dry in understanding the research that is out there and that exists. And we also hope to work with partnerships as best as we can like partners at the OCRC, the Ministry of Labor. We have partnerships with unions and other researchers too. And then lastly, on our website, we have many resources that we're trying to continue to create in order to get information to workers to really also break down some of those barriers related to vulnerability and discrimination, but also even, for example, language barriers. So next week, I'll just put the plug that we'll be speaking about vulnerable workers, and our program manager, Eduardo OHCOW, will be speaking about a lot of the projects that we're working on with agricultural workers specifically. So I hope you will all be able to join for that. And with that, that is my final slide. I'd like to thank you all so much. Specifically, there's many people on the slide here to thank, but thank you. Thanks to the Ontario workers who have entrusted us with their stories. A couple of names: Gord Assman, Rose Wickman, Jackie Duffy, Sue James, Janice Martell are some of the workers who've really been strong advocates who've helped us better understand how to serve workers. But also I'd like to really thank Dr. Paul Damaris, Dr. Kathy Slavic, Kate Witt, Holly Houston, and Kimberly O'Connell for helping and develop these kind of resources around cluster investigations that you've seen on these slides. And then thanks again as well to Dr. DeBono for sharing knowledge on the influence of industry-funded research. And with that, I will close and go over to questions.
Okay, thank you, Dr. Rhodes. Before we go to questions, I'll just mention that those are on WebEx who have access to the chat can find the link. They'll have to scroll back a couple of questions, but it is there, so you can provide us with feedback. You can also use that form to request a certificate of attendance for professional development. Those will be emailed in mid-December. And I will start by going through briefly some of the questions. I answered at least one. First question was around, do we come across cultural problems in reporting with injury or saving face? They gave the example of some regions of the world, and I already responded, so I'll just briefly say, yes, we do find in Ontario, we have construction workers, contract workers, temporary foreign workers, recent immigrants from some countries who are reluctant to report for a variety of different reasons. One is because the job may be precarious. One is they don't want to look bad. All sorts of different reasons. I am not aware of a paper that would help look for how to encourage reporting, but it is something that OHCOW is doing with some of our temporary foreign worker outreach. So David, who asked that question, will definitely be interested in attending next week. So it'll be talked about more.
Great.
The next question is wondering about whether the healthcare system does or could identify cases of Schedule 1 cancers like mesothelioma for follow-up. Sarah, is that something you can talk about briefly? That might be potentially our only question for time.
Yeah, so it is interesting. I absolutely think that there's use of, if in kind of expanding our reach into the healthcare system and also using administrative health data to better track cases that are coming forward for targeted follow-up, for example. However, I think what's coming to mind for me is that the best example of this is actually Ontario has a lung cancer screening program. So we've been trying to actually work with kind of proactively reaching out to workers who meet the criteria for lung cancer screening in order to then ensure that they're accessing those screening programs, especially if they work in high-risk industries. And then from there, encouraging or supporting with reporting if they do, in fact, have a diagnosis of lung cancer, being there as a support to guide them through that process to understand what it would involve to go through filing claim, but mostly and most importantly, regardless of the claim process, ensuring that they have access to prevention, further prevention resources that they need. So that's just one example I'll provide for now.
Okay, we do have time for one more question. It's from Denny. Hi, Denny. Nice to see you. Are there any other databases or initiatives that can complement my thing just reset. Okay, complement the information that OHCOW has on tracking WSIB accepted or rejected claims in rare cancer. Do you think a province-wide database might be feasible?
Yeah, well, it is really interesting. I think that we're always looking for ways to ensure that OHCOW's data is also just more, I think OHCOW's data alone is more accessible. We're really working on developing out our collaborative health record or electronic medical record system so that we can have more in-depth analyses. We're also working with new tools like REDCap, if some of you have heard of that, to track and more systematically gather work history information, health history information, so that we can do analyses of those and potentially even look at looking at a broader way of working with others to make a province-wide database, for example. So I think that's a great question. And, you know, of course, we're working with groups like the OCRC who have even more access to, you know, health data and other tracking systems. We've been working to try to look at also working with hospital connections, you know, at Unity Health, et cetera. So I think that it is feasible. I think that there's a lot of talk about expanding our data capacity at the ministry overall across all of the health and safety systems. So I think, Denny, you're on the right track, and that it's now just more about organizing and getting the momentum for it.
Okay.
But thank you for these questions.
Okay, I just invited anyone who still has questions to use the OHCOW Contact Us form to mention their question to Dr. Rhodes, and then you would get back to them.
Perfect.
I hope it's okay. I volunteered you to do that.
Feel free. Feel free. I also I am happy to I'll just put my email in the chat. I do not mind if people want to write me. So thank you so much.
Okay, well, with that, we'll close the session. Thank you, Dr. DeBono and Dr. Rhodes, for your time today. And I hope that everyone's appetite has been whetted, and we'll come back next week to learn more about vulnerable workers.
Thank you, everyone. Thank you, Krista.
Thank you.
And Megan. And Kate, who's in the background running the show.